Good morning. First patient is a 34-year-old female, status post fall off a motorized scooter with the left third metacarpal shaft fracture. She was placed in AP slabs. Next is a 76-year-old female, status post fall with the left distal radius fracture with associated ulnar styloid piece. Placed in a sugar tongue splint, was reduced.
Good morning. First, we have a 47-year-old male, left right hand dominance. That's his motorcycle collision. This left clavicle shaft fracture. He's treated closed with a sling. He'll follow up in the office. Next, we have a 15-year-old male. That's both left small finger P1 head fractured, a condylar injury. Unfortunately, the fluoroscopy images did not say for this patient, but we did 3 pins for him, one across, one transversely, and then 2 diagonal pins into the shaft. Thank you.
Morning. First case is a 66-year-old male, status post MVC with a left open Galeazzi fracture. He was initially treated in North Carolina where they put this X-fix on and provisionally washed him out. The opening was over the dorsal ulna and then presented here for definitive fixation roughly 10 days later, where he underwent a repeat IND and ORIF. We used a long metadiaphyseal plate because the proximal pin sites, there were kind of several cortical perforations when we exposed the radius, and we didn't want to leave a stress riser there, so we decided to go long proximally. The RWJ was stable intraoperatively after we fixed the radius.
Is there any risk of increased risk of infection when you bring your hardware to where the external fixator pins were?
I believe so, yes.
Actually, probably not. If you extrapolate from the tibia data, Ken Koval, or might have been Ken Eagle, wrote a paper on that, and the rate of infection really was not any higher.
Gotcha.
Obviously, you were if there was a history of bad pin sites and things like that, but if they had no history of pin tract infection, probably not.
Gotcha.
Was there a time frame on that, Carlos?
I don't remember the exact time frame for external fixator removal to then definitive fixation, but usually was two to 3 weeks.
The original paper was 21 days, and they had no pin track sign of infection, and that group of people did fine.
Right, that was the shock trauma Brumback stuff.
Is there any literature to support that a one little tiny 4.0 or whatever 3.0 hole in the radius is a stress riser on a non-weight bearing bone that needs to wait 3 or 4 months for it to heal anyway?
I'm not aware of any.
Sure, but
yeah.
I still think it's not a bad idea to bypass it if they looked at they had a couple of unicortical shots there.
If someone missed initially or put the pin, looking at the left, it looks like there's a hole right on the ulnar side. So from the sound of it, it sounds like someone put a pin in the wrong place initially and then had to reposition it. So there was probably more than one hole.
That's what it looked like when we exposed.
Right, but you're protecting this until it heals. You're not playing sports. You're not lifting. You have a fracture. And how long does it take for those holes to fill in?
6 to 8 weeks, maybe.
What percent of wrist fractures, or this is a radius fracture, but what's the chance that the hardware is going to have to come out?
I wouldn't say very high for this.
I know it's not very high, but they say 10% of them come out. So now you're going to now this was done through a big incision or a little incision?
It was a pretty big incision.
So you're gonna have to open up the incision. So I don't know, for, you know, it's not a weight-bearing bone. I don't know that you could treat them the same.
Yeah, we certainly had that discussion, and we thought it might be reasonable to use a shorter plate, but we just decided to go with the long plate.
Hey, Dave, if you had
Jeremy, I was going to say, when you examine him post-operatively, he has difficulty moving his thumb at his IP joint in terms of flexion. Why do you think that may be?
Worried about FPL?
So
Maybe
what
like maybe entrapped
specifically
in the
with
plate?
this, with your plate, you know, what happens to FPL right here?
You can get trapped under the plate if you don't expose superiously, or
No, not really. Where's the origin of the FPL?
it's up on the distal radius, or on the, sorry, on the proximal aspect of the radius.
Not really the proximal, kind of the mid portion of the radius. And the problem is with this exposure, you know, you basically strip a lot of the origin of that muscle off. So I've had that where I've gotten nervous that there was a nerve injury, but what it is that muscle has just been kind of, you know, taken off the origin, and it comes back over the next few months.
Gotcha.
I think the screw hole controversies, you know, we always talked about that when plating forearm fractures in athletes, and then, you know, do you remove the plates or not? And everyone talked about if you remove the plate, not letting them go back to contact sports for sometimes a year, because it takes that so long for the, you know, they miss a whole season for sure, because that takes so long for those holes to fill in, Dave. So
you think the 66-year-old guy is going to play for the New York Giants?
I don't think so, but you're asked a question about the stress riser of the screw hole, and the stress riser does stay longer than 6 to 8 weeks. It's probably a stress riser that's there for several months.
Yeah, I don't disagree with that, but you have to look at the person you're plating.
I'm not arguing that. I'm not arguing that point. I'm stating the fact that we had a discussion about the impact of a screw hole stress riser in a radius, and it's not insignificant, and it's significant for a relatively long period of time, longer than 6 to 8 weeks. That's all. I agree. The guy's 66 and he's probably not banging around on a field, but at the same time, you didn't understand the stress riser effect in a small bone like a radius.
Hey, we got some 66-year-old attendings that are still benching more than the younger guys.
The next case is a 62-year-old female status post fall while walking with a left distal radius fracture. She was initially seen in an outside hospital and splinted. She followed up in the office 4 days later where she had already started to displace. And so she was taken for a distal radius ORIF.
Do you think that it changed, or did you just fix it because of the recent article on JBJS that says you have to fix them all?
Both.
Did you read the article on JBJS from a week or two?
I have not, no.
How do you know what it said?
I need to read it.
I mean, the one in JBJS, which comes from the Netherlands, says that they should all be fixed, even if they look good. But everyone should be cautioned and read the commentary, because the conclusion really doesn't follow the methods and the results. I don't think this moved. I mean, you can make a case for fixing it, but this, you know, because of maybe the age or the function of the patient. But I don't think it displaced. I think you have two slightly different X-rays.
I think if you look at the piece of cortex looks like it's better keyed in on the post reduction, looks like it did displace. You can definitely see the carpus it's a better lateral in the office. I think it's translated volarly. So maybe it shifted, maybe it didn't. I don't know for sure. This isn't a true volar Barton where the fracture goes out midway between the dorsum and the volar cortex, but I don't think this patient's I think they would have issues long-term if you left it like that lateral in the office.
Well, the lateral looks the same. So I think that if you wait a year.
Do you think the carpus is centered in the axis to the forearm?
I think you don't, first of all, you don't have you have not a true lateral. All right. The ulna is dorsal to the radius. the carpus sits in the distal radius nicely. There might be a slight amount of translation, but overall it doesn't look bad.
Next case is a 40-year-old female, status post fall with this right distal radius fracture. She was initially seen at an outside hospital, but was unable to find follow-up due to some insurance issues. So she presented to us through the ED roughly 2 weeks after her injury with these x-rays and was taken for a distal radius ORIF.
Is that any different than the previous one?
Very similar, but she had a significant deformity of her wrist and it was very painful at 2 weeks. And so we decided she would benefit from an ORIF.
I don't think this has anything to do with pain. Everybody has pain at 2 weeks. This is very different from the last one. Here, the distal radius is translated more than 50%.
Yeah, that's fair.
So now the carpus, now the carpus is translated. You're starting in a bad position and it's 2 weeks and it hasn't been reduced and you're not going to be able to reduce it closed, or even if you could, you're not going to be able to hold it. And it's a 40-year-old. So I think the age is much different. The fracture pattern or type of fracture and displacement is much different. And so here, I think you're obligated to fix it.
Jeremy, if you let this fracture heal, what motion would be restricted?
I mean, you would probably lose some extension, maybe some pronosupination.
Yeah, so when you have volar translation or volar flexion, you lose supination. So another reason to consider fixing this right away is to restore maximum supination.
This is a 75-year-old female, status post fall down the stairs with a left trimalleolar ankle fracture with a very small posterior malpiece. She was initially splinted in the ED and was taken the next day for a ankle ORIF. Syndesmosis was stable after fixing the fibula and the ML. A 42-year-old female, status post MVC with a right distal radius fracture. She was placed into a sugar tongue splint, neurovascularly intact. This is a 93-year-old female, status post mechanical fall with bilateral proximal tibia and fibular shaft fractures. She is non-ambulatory, has a history of Parkinson's, dementia, factor V Leiden. She's chronically anemic, has heart failure on home oxygen. So she will be treated non-operatively in bulky knee immobilizers. She has some pressure sores on her bilateral heels as well.
Jeremy, on that ankle, can you go back to that ankle?
Yeah.
On the medial mount, it looked like you used a fully threaded screw that was pretty short.
Yeah. Yeah, so we put in 2 partially threaded cancellous screws. The second one we put in was the more posterior one. And it was pretty long it was going out posteriorly. So we decided to take it out and use a fully threaded cortical screw just to get purchase in the cortex.
Okay.
Good morning. First patient's a 13-year-old male, fell playing football, presented with this right radius shaft fracture. Patient was neurovascularly intact. Patient was close reduced, placed into a splint. After reduction, the RWJ was assessed, and it felt to be more lax compared to the contralateral side, but it was stable in supination, so he was splinted in supination.
How did you assess it? Just curious. How do you do that?
Yeah, so I did a shuck test basically, and it felt it still felt pretty loose compared to the other side, especially in pronation and neutral, but in supination it felt stable.
It looks like there's a distal ulnar fracture there, so I don't think that's a montasia. Isn't there a distal ulnar fracture there?
I know on this view, it looks like it, but I didn't appreciate one, especially when I was using fluoro to do the reduction. There was no distal ulnar fracture that I appreciated.
That's because you made the ulnar fracture and you stressed it.
Possibly. It's very possible.
It's tough to stress that joint with a broken radius. You're not sure what you're stressing. You can generally stress it after you fix it, but you can't really stress it beforehand.
There's definitely an ulnar fracture there. So I guess my question is, we talked last week about that same fracture that you guys took back to the OR to refix the ulna because you didn't like the DRUJ. So are we unhappy with this current DRUJ? Because the radius is pretty close to where it needs to be. So that wouldn't help anything. And the ulna has a fracture of it. So are we leaving the DRUJ like this, or are we supposed to do something about it at this point?
I mean, I think this is a different case than the one we showed last. One, the ulna is not as displaced, so that one was completely out dorsal on the lateral view. And this kid still has open physes, so he still can remodel somewhere, as the other child did not.
Yeah, I guess my point is I see a ton of these DRUJs that look like this in fracture follow-ups, and I leave most of them alone. And I don't know, sometimes when they get their follow-up x-rays, it looks like that. And sometimes when they get their follow-up x-rays, it doesn't look like that. So I have not been very aggressive with these, especially when they have both a radius and an ulnar fracture.
I think for the last kid, he also was locked and his supination was locked. So he also had a physical exam finding that we were chasing.
Yeah, but how do you assess that in this kid?
We didn't assess it immediately in that child either. It was when he followed up.
Yeah, I mean, it's pretty hard.
You can't assess it.
Right. Yeah, you can't.
Well, if you're really concerned, because it does look like it's fracture, and it does look like the ulna is not congruous on the lateral. If you're really, well, first of all, if you're really concerned, you could always get a CAT scan. I know you don't want to do that kid, but you'll know for sure if the DRUJ is lined up. This is concerning when you look at the x-ray.
Not a really good lateral though either.
No, agreed. But it was accepted and discharged. So in follow-up, if you can't tell on a good PA and lateral, there's always an option.
Dan, you said you splinted him in supination?
Yes, I splinted him in supination.
Maybe it should be splinted in neutral or casted in neutral.
It's also really hard to get a good x-ray in when they're supinated. So
yeah. Our next patient's an 88-year-old female who presented from a nursing home with unknown trauma, who was found to have this right tibial plateau fracture. ED had obtained a CAT scan as well, showing this lateral depression with associated split. Patient has a history of stroke and right-sided hemiparesis, non-ambulatory. So she was treated in a bulky knee immobilizer.
What's the anticoagulation in general for these, like for the bilateral injury? And the patient like a 80s, 90s, how long are you going to anticoagulate him for?
Yeah, so I mean, especially this patient's non-ambulatory, definitely, and with fracture now makes her higher risk for DVT. So I would at least anticoagulate for 30 days. We deferred to the primary doctor at this point, given all the comorbidities and history of stroke. But at the very least, aspirin, if not something a little bit more potent, like a Lovenox or a subacute heparin, since she's at a nursing home. Next patient says,
Brian, on thought of that's a difficult question, but I generally anticoagulate people with lower extremity fractures until they're back to the normal state. This lady's normal state is lying in bed. So I don't know what the answer to that question is, but I think there's morbidity to anticoagulation. It's not, it's more than you think, and I'm not sure what to do. There's not a real good answer to that question.
Yeah, this is very similar to the statistics we see for hip fractures. I mean, it's a real stress on the patient, and you got to tell the family that something bad can happen.
Next patient's a 60-year-old female, status post-fall with this right ankle trimal fracture. Patient was neurovascularly intact, initially provisionally closed reduced. taken to the operating room for ankle open reduction, internal fixation. Next patient's a 63-year-old male who presented after a fall while he was hiking about 10 days before presenting to the office with this left tibial shaft fracture. He was initially seen in another state and splinted. We don't have the original injury films. And CAT scan was obtained to further characterize the fracture pattern, showing extension of the fracture into the ankle articular surface with the posterior mallepiece that was non-displaced. Patient was taken for a tibial intramedullary nail.
That nailed purposely deep into the tibia.
Yeah, so this patient was actually initially planning to get a total knee done. And then he had this injury. So we did leave the nail a little bit short just to give him room for a prosthesis. And we actually put an end cap. Put an end cap that was that can be removed if it does get in the way of the prosthesis. Thank you.
You got to be careful with those end caps. We used to use them for the Smith and nephew nails all the time. If you strip the end cap trying to get it out, then you pretty much have no options to get the thing out. You're much better off leaving the nail hollow and cannulated, where you had a lot of other options to take out a nail if you strip it.
Morning. First patient is a 6-year-old male who fell from the monkey bars on Thanksgiving, who sustained this left type 3 supracondylar humerus fracture. He was neurovascularly intact. He was preliminarily splinted and taken that night for a left elbow closed reduction and percutaneous pinning. Next patient is a 60-year-old male who fell from standing, who sustained this left bimalleolar equivalent ankle fracture. He was initially closed, reduced, and placed into a splint. He also was noted to have a right ankle Weber B fracture that he sustained a week or two prior. That was stress negative. He had been ambulating on this already. He was placed into an air cast splint for this side, and he was taken the following day for a left ankle open reduction, internal fixation. Next patient is a 20-year-old male who fell from one of the notorious electric scooters in town and sustained this right femoral shaft fracture. He also had a left-sided non-displaced olecranon fracture that was splinted. He was placed into Buck's traction for the femur and taken the following day for a right femur intramedullary nailing. We also assessed the olecranon fracture to determine whether it was stable or that fragment was displacing on motion. It looked to be stable, so he was replaced into a splint.
And a piriformis nail.
Yes, piriformis nail.
Why did you choose that?
We just thought it would be an easier trajectory. So we did this lateral on a Jackson table, and we can just go straight down the femur with the piriformis entry. Next patient is a 92-year-old female who is reasonably healthy, although she has diabetes, who fell and sustained this left bimal equivalent ankle fracture. She was initially closed, reduced, and placed into a splint, and medically optimized and taken to the operating room for a left ankle open reduction and internal fixation. Next patient is a 67-year-old female who fell and sustained this right comminuted patella fracture. She was preliminarily placed into a Buckley knee immobilizer and taken the following day for a right patella open reduction internal fixation. This patient is a 62-year-old female who fell after Thanksgiving dinner and sustained this left distal radius fracture. She was closed, reduced, and placed into a sugar tongue splint, and will follow up in the office for likely surgical fixation.
Are you not happy about that?
I'm okay with where it is right now, but when I was reducing it, it was actually very difficult to maintain that reduction. It felt very unstable. It kept wanting to fall back dorsally. So I just think that when we see her in a week or whatever, in a few days, it's going to have fallen more dorsally again. And She lost a lot of her radial height and inclination based off of her post-reduction x-rays. And she's very active for a 62-year-old. I would, have a low threshold to suggest fixing it.
If it stays like this, what's the likelihood that the clinical results will be any different in a year? If you fix
If it
it at
stays,
all? If it stays like,
I mean, as is right now, she already has, a loss of radial height and inclination. I think, it's reasonable, even as she is right now, to fix it.
what is the number you're looking for? What radial height and what inclination is bad?
So you don't want any radial shortening greater than 5 millimeters, and she right where she is right now, she has like very minimal. So I think she's already lost more than 5 millimeters of height.
Are you saying the end of the radius is 5 millimeters shorter than the ulnar?
No, I think so. You're looking at the shortening from her her normal anatomy. So I think she has lost more than 5 millimeters off of her normal radial height.
Based on her loss of radial inclination?
I think, well, her,
Anna, I think let me interrupt you because you're making a great point, and I think this is really confusing in the literature because when some people measure radial height, they measure from the distal tip of the styloid to the level of where it articulates with the ulna. But I think when they talk about shortening, they're talking about where the radius is relative to the ulna, or more likely when we talk about ulnar variance. So when you look at like the ulnar variance here, do you see a difference?
I mean,
or are you concerned with the relationship at the level of the radius to the ulna?
I think she's right currently, as is in this post-reduction, she's slightly ulnar positive.
Maybe a millimeter. I would say maybe a millimeter. And what's normal?
I mean, within, like 1 to 2 millimeters.
Yeah, so normal is a millimeter negative, and to really know, we would need to take an X-ray of the opposite side.
Right.
I mean, just look on your lateral, and it's not really keyed in, and there's a chance that it's going to kind of accordion on itself and displace more. It probably won't go back to where it was initially, but you got to follow it closely. But I agree, like this is not quite the same sort of, volar Barton's type fracture. I mean, these sort of extra-articular fractures where the wrist ends up being a little crooked, the patients don't do that badly. And there's different kinds of 62-year-olds. So you just got to keep a close eye on it and be familiar with the literature and quote the patient what her options are. But you got to keep a close eye on this and see it weekly, I think.
Can you show that patella fracture for a minute? Okay. So what's your post-op management for that?
So she'll be locked in extension. She's protected weight bearing and extension. And that's usually for the first couple of weeks. And then you slowly just increase your passive range of motion over the course of, every couple of weeks in a hinge knee brace. So she's in a normal locked in extension knee immobilizer for now. We'll probably see her in 2 weeks, take out the stitches, and then put her in a hinge knee brace. And then weeks 2 to 4, you can start maybe 0 to 30 passive range of motion. And then every 2 weeks, maybe 0 to 60. And then hopefully by week 6 to 8, she'll be at 0 to 90.
Can you tell us about the quad mechanism? Was that ruptured on both sides or one side?
For quad tendon?
The retinaculum.
The retinaculum. There were retinacular tears on both sides that were repaired after the plate was put in. Thank you.
Morning.
First patient is a 12-year-old male with a left skiffy. It was a chronic skiffy, minimal slip for this kid. It was stable. He underwent a left hip percutaneous screw fixation. Next patient is a 9-year-old female, status post fall with a type 3 supracondylar humerus fracture. Underwent a left elbow CRPP. Next patient is a 9-year-old male, status post fall with a right both bone forearm fracture. Underwent closed reduction and was placed into a sugar tongue splint. Next patient is a 12-year-old male, status post punching the bed with a left second metacarpal neck fracture. Closed reduced, placed in an AP slab. Next is a 70-year-old female, status post pedestrian struck with an open right distal femur fracture and an open right medial epicondyle fracture. She had a large degloving injury on the medial side of her right thigh that was managed by us, and she also was found to have no pulses, no Dopplerable pulses initially, and then they were able to be Dopplered, and her ABI was taken to 0.38. She underwent a CTA. She was eventually underwent an angio, was found to have a popliteal thrombus, underwent a SFA stenting with vascular surgery. Here's our CT. X-ray of her elbow here, showing medial epicondyle fracture, which was a poke hole opening. She underwent an IND and was placed into a posterior splint for this medial epicondyle fracture, and she underwent a right distal femur list plate for the distal femur fracture. Next patient is a 33 male, status post fall downstairs at his home with left bimal-equivalent ankle fracture.
What was the timing for that? Did you guys X-fix it provisionally or?
So
fix
no,
it in the
we actually did not. We consulted vascular surgery and the trauma surgery team, who basically said that she was okay for definitive fixation and recommended definitive fixation. We initially had planned to X-fix her based off of her vascular status, but they said that any procedure that they would do would be after we definitively fixed it. So we actually went ahead and definitively fixed it. They then took her for an angio and discovered all this popliteal thrombus, and eventually they first tried to do an IR thrombectomy. It sounds like that failed. They then had to do a mechanical thrombectomy, and they did this graft procedure.
But she had blood flow while you guys were doing this, right? I'm assuming.
She had Doppler.
They felt she was in spasm. She had Dopplerable pulses. Exactly. So we thought about X-fixing her. I pretty much figured I could put this list plate on as quickly as an X-fix almost, which we pretty much did. We did that in about 40 minutes, and then get her to IR to really see what was going on. But she did have normal cap refill, and she had Dopplerable pulse, so we went ahead. Then the shit show began.
Yep. Next patient is a 33-year-old male, fell down some stairs at his home with this left bimal equivalent ankle fracture. Stress was positive, borderline to about 5 millimeters. Closed reduced, placed into a short AO splint. Next patient is a 78-year-old male, status was fall with a left hip intertrochanteric fracture.
So John, on that ankle, if that were you, what would you choose as your treatment?
I would probably fix it.
We need you back to work.
When would I go back to work?
No, I'm just saying we need you back to work. So what's going to get you back quicker?
What was that? We need me for next call shift. Yeah, probably fixing it. Yeah. You could also use like scooters. Probably do some work with this.
there was not a controversial, but there was a study out of Canada for these Weber bees a while back that said to do better with fixing it because you can return quicker. That hasn't been, if it's well reduced like that, technically you could leave it alone, but in terms of returning to work quicker, and now there are studies that are evaluating early weight bearing at 2 weeks if you fix even trimals appropriately. So if it was my ankle and I wanted to go back to work, I would have someone who knows what they're doing to fix it, so I could walk on it and get around quicker.
When do you allow a tri-mal to weight bear, one that you have fixed, say posteriorly?
Usually mine was 6 weeks, but younger and fixation I have now done people at 4 weeks as well. I'm kind of selectively choosing it, I guess, at least until the results of this multi-center study comes out, which they're showing that after 2 weeks, because there's complications with skin healing if you do early range of motion and early weight bearing. So after the skin heals, which is usually around 2 weeks, then that's when they're looking at 2 versus 6 or 8. I forget what the numbers are. But I have started certain people, if you fix all the mouths, so to speak, at 4 weeks, and then progress from there.
So yeah, so John,
I think it's safe at 4 weeks, but in theory, I'm not going to see them at 2 weeks post surgery, and then again 2 weeks later to start weight bearing them, and probably another 2 weeks after that for another X-ray. So I pretty much see them at 2 weeks, make sure the wounds are well healed, transition to a splint that they can work on range of motion, everything else. I keep them down weight bearing for 6 weeks. I don't see a huge advantage to getting someone walking 2 weeks earlier.
So John, if this were you and you had it fixed, I would assume you probably could be back to work at 2 to 3 weeks with like a kneeling scooter. Whereas if you treated it non-op, I'm guessing you'd probably be in immobilization much longer.
Let's not put me into any boxes. 78-year-old male, status post fall with a left hip intertrochanteric fracture. He underwent a left femur IM nail. Decision for the nail. For the long nail is that he had this total knee replacement distally, just kind of prophylactically.
First patient is a 3-year-old male with osteogenesis imperfecta as a minimally displaced humeral shaft fracture is put into a Sarmiento, which he already had on the fracture. Next patient is a 71-year-old female. She was on unrestrained prior majority MVC. She had a right non-displaced fibular shaft, a proximal third, and a left zone 1, base of the 5th metatarsal. She was weight bearing and tolerated bilaterally. Next patient is a 21-year-old female. She was in a motor vehicle accident 4 days prior. She had a right distal radius, close reduced, put in sugar tongue splint. Next patient is a 41-year-old female on MVC. She had a left distal radius fracture. She was close reduced and put in sugar tongue splint. Next patient is a 9-year-old female with a left distal tib fib fracture. She was placed in a long leg cast. Next patient is a 9-year-old female with a Salter Harris 2 distal radius fracture. She was close reduced and placed in sugar tongue splint. Next patient is a 6-year-old male with a distal both bone forearm fracture. He was also close reduced and sugar tongue splint. A 68-year-old female, that's post ground level mechanical fall, trimal ankle fracture, subluxation. She was close reduced, splinted. We got a CT demonstrating a large posterior mal, vertical, medial mal with a transverse component as well. She was taken to the OR for definitive fixation.
What's more important than just the size of that posterior mal piece on your lateral? Go back to your lateral.
Articular step off,
Yeah, and what else?
comminution,
Well, even in your splint, your bottom right film.
your subluxation.
Yeah, in your splint, right, the talus is subluxed, right, posterior.
Good morning. First patient is an 8-year-old girl, Cesspit fall, the right supine fracture type 2, vascular attack. She's taking the OR for CRPP.
Morning. The first patient is 74-year-old female, status was 4 with right distal radius fracture and left fifth metacarpal fracture. Patient was initially cross reduced, but she couldn't maintain the reduction, so we decided to take the patients to the OR for right distal open reduction internal fixation, and left fifth metacarpal fracture was close reduced and splinted. Next patient is 79-year-old female, status was fall with right femoral neck fracture. Patient was taken to the OR for right hip hemiarthroplasty. Next patient is 30-year-old male, status was MVC with right femoral shaft fracture, right second to fourth metatarsal fracture, and first metatarsal phalangeal joint dislocation. The patient was taken to the OR for right femur IM nail, close reduction of the dislocations of the first metatarsalophalangeal joint and splint. Next patient is 30-year-old male.
Did you do that on the fracture table or lateral?
We did that on fracture table.
And you used a piriformis nail or a?
No, you did trochanteric entry. Next patient is 30-year-old male, status was MVC with right humerus and right bone forearm fracture. The patient was taken to the OR for right bone forearm fracture, open reduction internal fixation, as well as right humerus open reduction internal fixation. Next patient is a 52-year-old male, status was MVC with a bilateral femur fracture. There was open fracture on the right side, segmental fracture on the left side. Patient was taken to the OR for right femur IND, bilateral femur IN nail, and additional plating on the left side.
So why the plate, Andre?
So we put the plate for two reasons. The first, there's a lot of comminution, and with the nail, we get like one good screw distally, and the second screw was questionable. And we add extra fixation for that. And the second reason is with this construct, we allows the patients to weight bearing as tolerated on both sides. Next patient is 29-year-old male.
Worry a little bit. I'm just saying, you know, that it looks great. Obviously, I think it's going to do fine, but you had a plate now on top of a segmental fracture. You've significantly reduced the strain there, especially, you know, they're both areas that don't like to heal. You know, this could impede healing a little bit, especially that proximal one, but we'll see. I think it'll be fine.
We put titanium plate, so it's like less stiff on the sides.
And we try to bridge it, that the segmental shaft, the screws, although there are a couple of screws, they're not that great at fixation. Essentially the two proximal screws are doing some work in the proximal segment and distally. So it's except for the couple of screws in the middle, they're essentially bridging all of this. So, and plus, if he's weight bearing right away, so there's going to be more motion if he was not weight bearing. So hopefully, we didn't interfere with the biomechanics of it.
Yeah, like I said, I think it's gonna be fine, but obviously, it's a high energy, it's open. Now you've probably done an open reduction on both of those. So you've messed with the biology a little bit and you've made it more rigid, but you're gonna let them weight bear. So it's a tight rope a little bit, but I think it'll be fine.
Next patient is 29-year-old male, status was fall with left bimal ankle fracture. The patient was taken to the OR for left ankle open reduction and internal fixation. Next patient is 11-year-old female, status was fall with right femoral neck fracture. The patient was taken to the OR for right femoral neck close reduction and internal fixation with the proximal femur locking plate. Next patient is 9-year-old male, status was fall with left A3 supracondylar humerus fracture. The patient came with the AIN palsy. He was taken to the OR for left elbow close reduction percutaneous spinning.
What do you tell the family about the AIN palsy?
So we told the family that in 99% of cases, the nerve function will come back. It takes some time. So after surgery, there was still palsy. So we think that it's a neuropraxia and he will come back in a couple of months.
Yeah, the best prospective studies say it's probably like 94%, but yeah, generally reduce them, they get better. And there's really two classes. There's the ones that get better acutely, where it's mostly just tension on the nerve and swelling. And usually you see them improve in a day or two after the injury. And if they don't improve that quickly, then it's going to take a couple of months. And that's, kind of basically how they stratify out.
Okay. Thank you so much. That's it.